right, so thank you again. I just thought I would cue high flow nasal cannula and start this roundtable discussion on the use to treat hypoxemic respiratory failure. And I just grabbed, some general thoughts out there. I do use regulatory terms sometime, but this is clear that there's the clinical indication that I see firmly being presented in the literature is the indication for treatment of hypoxemic respiratory failure. The intended use is how the device works or what it's intended to do. And I could, I'm just saying that it's delivering warm, humidified, blended gas, O2 and air, FiO2, if you will, or O2 concentration at higher flows than conventional O2 therapy. And I think that's a pretty simple explanation or intended use. I am going to also recognize this document, which came from the Intensive Care Med, Society of Critical Care Medicine, where they acknowledged also when we should use or indications for the use of high flow. And their strong recommendation was, of course, hypoxemic respiratory failure, then a conditional recommendation for following extubation, post-extubation. I'm sure there's patients who might be at risk, perhaps even inadvertent extubation, and then post-operative high flow nasal cannula in high-risk patients, obesity, some cardiac and thoracic, and then they said moderate recommendation or no recommendation, on peri-intubation. So that has come out of the Society for Critical Care Medicine in 2020. And I think really the scientists here, whether they agree that the alveolar gas delivery is going to be dependent with this device on the flow rate of the gas, the blended O2 mix, the patient interface, the patient's inspiratory demand. And I would say to some degree, the overall therapy effectiveness, as we know now with active humidification, is also a element of effectiveness or efficacy. So my question to you guys, and I'll list the questions and then we can start the discussion. Do you agree with these indications? Do you have any contraindications for the use of high flow nasal cannula, O2 therapy? What flows do you typically find works? Do you try to match demand? Is this an issue of providing as much flow as the patient will tolerate from a comfort standpoint? What kind of flows do you see being used in pediatric and adult patients? And then the other question I have is, what temperatures at the port do you typically set? The standards 806.01.274 calls for a patient port to be at 37 degrees, but I see devices that allow for 34 and lower temperatures as well. And I thought it might be helpful if I got out of this and gave you guys a quick look at pre-pandemic to our current state. This is the FDA's total life cycle, and this is the product code that you would find it under, the classification. We see that recently Fisher-Paykel has released some new stuff. I think this might be a nasal cannula. They had their new device as well, and I have the 510K, which is the OptiFlow nasal cannula, and Permapure and Vapotherm. But I think it's important to look at, in 2021 alone, we've had 790 MDR reports and MDR events. Now, usually these go one for one. When you see them more than one for one in the report. And then the problems that people are complaining about with high flow use is no audible alarm, insufficient heating, failure to power up, leaks, splashing, cracks probably in the chambers, fluid leaks, breaks, etc. So that's kind of a overall look at high flow, both from a hopefully clinical purview and also from a market purview. So I'm going to stop sharing now and ask you, are those agreeable indications? And I can pull up the slides if you need to peek. What do you guys, are you using high flow? Have you increased the use of high flow?
So we've had a huge experience with this. We've been using high flow for, I was trying to find out the other day how long, for probably as long as it's been on the market. It was released early in New Zealand, and we use it on everybody. In fact, the problem we have is particularly the high dependency patients, you go, someone tells you they're a bit hypoxic or short of breath, and you say, I'll put some high, they're already on it. You turn around and say, the nurses, put them on high flow, they've already got them on it. It becomes the standard treatment for anybody with respiratory difficulty. So we use it all the time rather than it being a specific therapy. Some of that I agree is probably wasteful. We could save money and by doing it less, but it's the default now for most patients. And we use it for all the indications that you listed there, plus some others. We've found it is useful in many patients with work of breathing COPD difficulties. We believe it has an effect on washing out CO2. It's not, there will be patients that benefit from non-invasive on top of that, but a lot of patients get away with just high flow. And it's certainly incredibly useful for the perioperative, post-operative extubation, high flow, and post-ICU extubation as well. We often extubate to high flow. We have the high flow running prior to them being extubated. The high flow is running as we extubate them, rather than waiting, taking the tube out and putting it on. They're connected and running at the time that they're extubated. The contraindications, there are some there. I don't think they're common, but there are some issues. If undrained pneumothoraces from trauma, it's often used in chest trauma, and we often use it for the mild to moderate chest traumas, but undrained pneumothorax is always a worry because you're applying a positive pressure. Same with facial injuries and upper GI injuries, so it can be a problem. That there's a positive pressure at the time they breathe in, and that may cause damage. So yeah, I mean, to us it's like IV fluids or standard oxygen. It's not a novel treatment anymore.
So what is your experience on flow rates? Do you guys think the devices provide sufficient ranges currently?
So we're using increasingly high flow rates in adults. In kids, we use high flow rates, but the numbers aren't a big issue. We're using a lot for RSV. We're having an outbreak of RSV this year with sort of an incubation effect. There was no RSV last year, so they're all coming with bronchiolitis now. We had a horrific week 2 weeks ago with just hard argument. So we use 2. They say recommend 2. We use up to 3.5. We don't really mind litres per minute of high flow in the kids, but that's never a large volume that you can get that out of the machine. The adults, 60 or 70 litres. I think the Fisher & Paykel 950 is rated to 70 litres, I think, per minute of flow. I have been tempted to try and put 2 high flow devices, 2 humidifiers, either in series or in parallel, and I think either would work. If you think about it, you could put half the flow through each one, or you could put a humidified gas throw through both devices. Either way would give you a better humidification. They think that after 70 litres, the humidification drops down a lot. Their settings are, I think they're aiming for 34, is it 33.8 on the 950 on the mask setting, which is what we use. Mm-hmm. Some patients complain of the heat, not all of them, but if you put it on the invasive ventilator setting, that they don't like that. We were toying with an idea of putting a cold air spray over their face, because what they don't like is the heat. I think the humidification is important, but they don't like the heat, and we've looked at various ways, just like they are at the Olympics now, the tennis where they had those cold air jets coming out. That might be a useful thing for patients, because they often find it's just hot. That's all. Not as hot as a mask, to be fair, but they still find them a little bit uncomfortable.
Yeah, I know that the literature indicates that there's improved compliance with heated and warm gas, and maybe that's over a longer period of time. But I know a lot of COPD patients I treated. If I got anywhere near them with something warm and blowing, they would have a fit.
Yeah.
Are those the patients that most?
Yeah, but most don't mind. But sometimes there's patients that just find they take it off because it's hot. The compliance, as you say, this is the patient compliance, not their respiratory compliance.
Right, sure.
No, it's all right.
Non-elastic compliance.
Yeah, it's pretty good. I mean, we think one of the reasons it works so well is because patients aren't tearing it off. When we used to use a lot of high flow oxygen through a mask, just a standard mask, and the compliance was often given through the hair or the left or right ear, because the patients would be taking it off because it was hot and uncomfortable. The nasal cannula seems to be more comfortable, and patients are more compliant with it. And that I think that's one of the reasons it works. Some while ago I wrote an editorial about why non-invasive ventilation doesn't work for hypoxemia, or doesn't work as well for hypoxemia while it works for COPD. And my theory was that it's because of the compliance. Part of it is the compliance, that patients take a non-invasive mask off and then they drop their alveolar, the alveolar collapse when the pressures aren't applied. It takes a while for them to be reinflated. With high flow, it's on a lot of the time, and that might explain the difference of why in the Ferrari paper that they got a benefit from high flow, didn't get a benefit from non-invasive, when you think they kind of do the same thing, but they don't quite.
If I can just jump in for a second, Ross, and I'm not here to be the lead in the discussion, because that's you guys. But back to Steve's point about the flow rates. Yeah. How do we know what the optimal flow rate really is? Is it because it's only as large as the cannula, which allows the flow? Or do you say you have a little person, not a child, but say like a little old lady, she doesn't probably need 70, does she need 30 litres per minute? How do you determine optimal flow?
So we do this really scientifically, Graham. In some patients, if they're being ventilated, about to extubate them, if we remember, that's why it's scientific, we will actually measure their peak inspiratory flow, and to give us an idea of what that is, and we try and match that. But that most of the time, that's probably a load of rubbish, really, because they will breathe differently. Size of the person is obviously important, but also their respiratory rate and effort. Some patients are working incredibly hard and they need higher flow rates. It's kind of obvious, but the idea is to match the peak flow rate so that you don't drain air, and particularly dry air, but also air into them, and what they're getting is the whole gas flow. The other thing about the flow rate is kind of, you get about, well, it depends on whether you open your mouth or not, but you get about 0.6, 0.8 centimeters of water. It should be called PEEP, really, because it's not across the whole cycle, but an inspiratory flow support of pressure. So there is a pressure effect, and I noticed in the slide, Steve, that you talk about oxygen being delivered to the alveolus. It's also a pressure possibly being delivered to the alveolus. Hard to find strong evidence of that, but there's Rachel Park's paper from a few years ago now showing there's about a 0.7, 0.8 centimeters of water for each litre of flow. So if you've got 40 litres, you expect to have 3 or 4 centimeters of water of positive pressure.
Each 10.
Which isn't much, but when you think about it, if you've got a patient, you turn the PEEP from 5 to 7, you see a huge oxygenation effect, and I think that's what we get with the high flow. You've got no PEEP, and you give a little bit, and the oxygenation does improve, and often they're weaker breathing. So.
So I kind of look at it differently too. I noticed in getting ready for this discussion, I looked at a few different kind of major articles, found that in the pediatric application, they were more concerned about a tight-fitting nasal interface and nasal prong, and they really wanted it to be, they said, not sufficiently leaking, but also not extremely tight. Where when I looked in some of the adult literature, they seem to want a tighter fit around the nasal prongs, and it seemed to me like that was going back to our old mean airway pressure discussion. That might serve as a benefit for oxygenation in these adult patients, and the infants are, of course, subjects of their own.
Yeah. I think there's a concern about the obligate nasal breather that some of the kids don't breathe through their mouth. For adults, when they get short of breath, will open their mouth. So there's never, if there's a flow restriction, they will open their mouths, and that's overcomes it. The kids don't necessarily do that, particularly those that are being apneic, and that's a concern. And we've now, the Starship, the national pediatric guideline here sort of says that you don't turn the flows down below 2 litres. You simply take it off because they're concerned that there will be a flow restriction if the cannula on kids will be fitted tightly to their nose. They can't breathe in around them, and therefore they'll have flow restriction. So we turn the oxygen down, titrate that down to room air, but the flows stay at 2, and then they just come off. Adults, we don't do that. We often run flows of 25 or 30 litres, down to 15 even sometimes. Usually we get to 15 we think, well, it's time to take it off. But so, one of the things I'm not sure how much, I don't want to talk to the converter, but there's 4 things that happen is that you give a constant inspired FiO2. You're giving humidified gas, which it's not always, that's hopefully you're meeting the peak flows. You're providing a positive pressure, which varies, but there is a positive pressure in the big airway. And the last one is that there is a flushing effect that normally when you and I breathe in, it's from our mouth, and we have mixed gas in our upper airway, oropharynx and mouth. With this, it creates a one-way system. Hopefully, the gas goes in through the nose and comes out through the mouth. And so the fresh gas is available at the back of the larynx. That reduces the tidal volume that's required by about possibly 50 mils in an adult, which is a tenth of a tidal volume or more than that. So that's the work of breathing reduced, and we think that possibly has an effect. There's some work done by a guy called Callum Spence, but who worked for Fisher and Paykel, admittedly, and he's shown that should reduce the minute ventilation by a proportional amount. So dead space ventilation is less. So.
You raised I'll quit talking after I make this comment and let the rest of the guys dive in, but you raised an interesting question. I did read during the pandemic in India, they didn't have oxygen, but there was still some potential value in employing high flow because of that fact alone.
Yeah, I think that's correct. We've currently got a problem in Fiji, which is, 800,000 people. I think about 30% of them got COVID at the moment. It's just awful. Wow. They ran out of oxygen the other day, and I was talking to I've got some colleagues up there. In fact, we trained the guys up there, and I said just run them on they've got Hamiltons. And some Airvo. I just run them. I said it doesn't matter it does matter you run out of oxygen, but there is a benefit, and they're trying to do that. Just give them gas, So
from a metabolic,
they can't get enough oxygen. It's
terrible.
All
It's terrible. David, I know you have been a big advocate of high flow during the pandemic in the treatment of your patients with COVID-19. Can you give us your thoughts in this area? What are we on with those indications? Are there contraindications that we haven't thought of or that we should be thinking about?
Well, first of all, I'd say independent of COVID, I think our use of high flow sort of mirrors what Ross has said, and that even before the pandemic, we had sort of rapidly escalated our use of high flow and broadened our indications for it over the last, I don't know, 10 or 12 years, however long we've been using it, maybe more. We use it for all those indications, and a newer one in the last year or two is as part of our inflation scheme for patients following cardiac surgery. So as you might know, some years ago, we picked up a practice of using BiPAP intermittently, postoperatively in cardiac surgery patients. Almost, well, as part of an algorithm, but fairly early, we would use intermittent BiPAP, 1 hour QID basically. And that was based on one of our colleagues at another hospital who was using it, and all the cardiac surgeons liked it. And there never was really the kind of robust outcome data that would support that, but a lot of physiologic data, and made common sense. So that was part of our algorithm. And then a few years ago, there was an article comparing high flow nasal cannula versus BiPAP, or non-invasive ventilation, following cardiac surgery, following extubation from cardiac surgery in patients who develop respiratory failure, defined in several ways. So they compared the two in terms of whether it would prevent reintubation or some other complications, and they basically were equal. Now that wasn't as an inflation scheme, but our respiratory therapy department kind of took that information and turned that into an alternative. So now at two of our hospitals, if you have cardiac surgery afterwards, and if you don't have a robust inspiratory effort and any sign of atelectasis, you're liable to get either high flow or BiPAP for whatever either of those are worth. I can't think of any other obvious contraindications for it. It's more a problem in terms of going too far before intubating someone who actually needs it, and that of course has potentially been a problem in the pandemic, where we've after not too long after the early phase, we just started using high flow in almost everybody who needed significant amounts of oxygen. And knowing when to intubate them is obviously is difficult. There's that ROX index that people have utilized and now modified when using the heart rate. And we haven't really not so much used that, but rather more just clinical observation and judgment. With respect to the flow rates, I think we kind of do the same thing as Ross. We kind of do have a bit of a protocol that the respiratory therapists use, where they start, around 30 or 40 initially, and we'll go as high as 60 or 70, but that's pretty much as high as we'll go. I kind of feel like from talking to patients, it's unlikely that many of them would really stand more than that. They're the same sort of problems with some people don't like the humidity and the heat, surprisingly, and I try to sell them on it, but that has been a problem. I think, like Ross, we've used it in quite a few patients who have a COPD exacerbation, where the standard teaching might be that you use non-invasive ventilation. But I think, and it's been successful in some, and I think maybe that component of CPAP or PEEP that you get with high flow may be part of the equation that makes that work, especially for those that might have a little bit of intrinsic PEEP or dynamic hyperinflation, the same way that we think PEEP in a COPD on the ventilator might be helpful in terms of their inspiratory triggering. So maybe that's at play. Maybe somebody has done some sort of experimental work using esophageal balloon. I don't know, but clinically it seems to be worthwhile. I would say also echoing Ross's comments, what it appears to me is that the high flow nasal cannula has sort of replaced the extended use of a non-rebreather mask or a partial rebreather mask. So we might have a patient who gets one of those placed on in the ER or early on in the hospital, but I mean, if they're on that more than a couple of hours, we're going to switch them to a high flow nasal cannula. They don't like having the mask covering their face. We feel like the high flow is a little more effective. So,
And it's still a low flow therapy, even though it's
we've gone to a much more expensive form of therapy than a 5-cent non-rebreather mask.
But the non-rebreather is still in that low conventional realm of flow anyways. So you probably don't get the FiO2s that you purport.
Right. No
That-
doubt. Although no doubt we're also treating some patients with high flow that we could get by with a non-rebreather or even a Venturi mask.
Ehab, what's happening in Hawaii?
So pretty much the same, I've been using it over the last couple of years, but of course, over probably last 2 years, it's exploded probably like everywhere. We use it much more to the point is like we've been urging the hospitals to buy more, but like say small hospitals, we have like 5 or 7. So most of the time, I need to use a high flow was like, well, it's all being used on patients right now. I always struggle with the flow. I know respiratory start with the 20, 30. And in my mind, I always want it as high as possible. I want to go to 60 because as you said, like I can't measure the patient's inspiratory flow, what their needs. Am I am I less than they're pulling, by 30? I don't know. I worry about like how much really PEEP, if I'm creating any PEEP, which is I want to. So I always tell the patients, just please shut your mouth, or somebody PEEP somebody like when they're like, I'm assuming it would like the more you talk and they're eating, that would be much less pressure. But I get the patients complain usually when I try to go 60 or something, they're like, no, too much. And they try to take it, the same with sometimes they complain about it's too cold or too hot. Can you increase the temperature? Can you decrease the temperature? And so it's pretty much echoing the same, like as you said. During the COVID, I've been using it a lot. I think it's pretty successful. But I still use it mostly for the hypoxic respiratory failure. I never used it just for somebody coming with COPD exacerbation. And I say like, oh no, it's much better than non-invasive positive pressure. So let's put him. I never ventured to that. Use it a couple of times during bronchoscopy, kind of high risk, and I don't want to intubate the patient. But of course, it's become so hard to go from the nose with a high flow. For pre-oxygenation, pre-intubation, I mean, if I ask the respiratory therapist just to set the high flow, it takes them 10, 15 minutes just so I can oxygenate the patient, they would kill me. So unless the patient on it before, I would just keep it running during intubation. But so my major issues again is like how to set the flow. And I go empirically like 30, 40, 50, I try to go up as 60 or 50.
Great.
Yeah.
Ross, you have your hand up. I don't know how to respond to that. I'm not an expert in these systems yet. Anyways.
So just a couple of things about that. One of the things, all our patients are ventilated for anything more than about 10 minutes get a water bath humidifier, and that makes the conversion to high flow and extubation easy. And I think I realized the other day, because we use water bath humidifiers, and now we often using the high flow that's built into the ventilators rather than standalone units. Mm-hmm. That makes it easy because we're using the water bath humidifier. If you're using an HME, of course, there's a extra bit you've got to add the water bath humidifier into the system, so that makes it not quite as efficient. We're not going to change our practice, but just if people are thinking about it, that's another advantage of using water bath humidifier. The other thing, just for Ehab, I think that the flow thing, which flow to set is difficult to know, but we often start with lower flows. I think one of the things that puts patients off is using a high flow. I think it's the same principle we use for non-invasive. You drive in a car and it's doing 100K, you stick your head out the window, it's hard, and your head gets ripped off. But if you stand and put your head out the window and you accelerate the car to 100K, you don't notice. And I think it's the same with non-invasive, but also the flows. You start at 10 litres a really low flow and just wind it up over time, and they tolerate it better. I think the Bella Vista has now a thing where you can have a ramp, so it starts at a low flow and winds up over 10, 15 minutes if you want it to. I've never used that much clinically, but it is there, and we often our nurses want to start, if patients don't tolerate it, just start at a very low flow and just crank it up over 20 minutes or half an hour, and they like it. It's worth getting your staff to try it too, put them on it, and the fit, healthy people, the super athletes, they hate it. They don't particularly like it, but people who have slight lung disease or morbid obesity, they think it's more comfortable, which is an interesting thing. But if you're fit and healthy, it probably increases the FRC too much. But people who aren't so fit, they actually find some benefit from it. So,
hey, it's respiratory training for those athletes.
yeah. It is, they probably oversplit themselves. Yeah, they don't like it. So,
yeah. I can understand.
You know, if I might, just one comment. I think still, even it's been available for the last, I don't exactly know, like 10, 12 years, maybe more, I don't know. I think we're still in the beginning of it. I think we need more studies, like, you know, especially now, again, it's incorporated in ventilators. You can make more measures during like the high flow, like, you know, for patients flow, how much PEEP, stuff like that. So I think we're still infancy in it, and I think things will know more in the next, I don't know, 5-10 years. You know, that's my thinking.
Is there something missing? I was kind of asked this question because I'm a device nerd. Is there something missing in today's high flow devices that you wish you had? I know that we had Stephen Dawn join us about a month ago, and one of the things that he said he wished he could see was actually a pressure measurement at that junction. If the device provided some level of pressure measurement, he would be interested in it. Is there anything else? Do you guys agree that you would like to know the back pressure that's being sensed at the patient airway, or is there other stuff you'd like to have, like a ramp that was discussed, or other sorts of things you think would be make your application easier? I'll give you another example. I see all kinds of different circuits being used. If you look at the Vapotherm approach, that circuit is very laminar, non-compliant. So I imagine force that's generated is quickly displaced to the patient. It's certainly not lost in the circuit. I know they call it, they have some marketing terms for it. Would you like to see uniform circuits? Would you like to see, what's missing from high flow?
How about end tidal measurements? I don't know if anybody used that, or because I thought about this before and I couldn't do it. And can you measure, like, even I don't know, how can you monitor it otherwise?
Yeah.
Where do you measure it from? Because if the air is pouring out of the mouth, it's one of the problems. You got to.
Your entitled CO2 will be low.
That's right.
Because it's diluted by additional gas flow, which is an issue. And I think the same thing applies. It'd really be good to know, hard to work out, what the humidification that is required, because if comfort is an issue, then if you could turn the temperature down and have less absolute humidity, so you keep the relative humidity at 100%, but that would be less absolute humidity.
Yeah.
If that was tolerable, because you've now got the upper airway as a humidifier, so it doesn't have to be 100% humidified, but at some threshold you'll be dropping it down, and you've got to be drying out the trachea. But at the you don't have to have 100%. It's not like an ET tube, because you've got the nasal pharynx and that to humidify the gas. Yeah. But the high flows are a problem because they are very drying. So be able to monitor that and maybe turn the temperature down might help. To know if you could measure from the back of the throat what inspired oxygen you're actually getting would help with the flow calibration.
I think, Ross, we probably waste, and I'm saying we as a general comment, we probably waste a lot of oxygen, right? Because you think about, you go to your hospital, and if you had, like, in your ICU 10 people on 40%, I don't think breathing 21% is actually what everyone's breathing. All the staff are probably breathing 30% plus. Maybe the future will be pressure, and then the flow will adapt to pressure.
Yeah.
Can I make a comment on that, Graham? Related to that, not about the pressure, but what Ross described as a situation in Fiji reminded me that in the worst of our surge here in Southern California, Los Angeles, which was the worst affected, city in the state and maybe in the country at the time, there were multiple hospitals there that were literally running out of their oxygen supplies.
Yeah.
And, it makes one wonder if you have, 50 or 100 patients in the hospital, and some would, on high flow at 70 liters a minute, and they're 100% FiO2 because they're that sick.
Exactly.
It would be we all have these giant liquid oxygen tanks. Most hospitals do, Air Liquide or others.
Yeah.
It would be an interesting mathematical exercise, first of all, to figure out, how long it would take you to, deprive your cylinder. But I was concerned enough at the time when I was hearing these reports from LA, though we didn't have the problem, that I talked to the managers at the hospitals that I work at. I said, look, we need to be ever more vigilant in getting people off of unnecessary oxygen, non-COVID people who are, just sitting on the floor getting 5 liters or more. I mean, we way over-treat people with oxygen in hospitals. That's, a matter of record. And not just the high floor people, obviously, but, I was just worried that we were going to run into that. So we were trying to be cognizant of it. We never got close, I don't think. Thank God.
There have been problems with actual gas flow through pipes. The mains reticulation is not big enough to do it.
Yes, they were freezing because they had such a high draw from multiple different ports, that the pipes were freezing and rupturing, which put you
regulators
out of business.
The regulators get very cold. Yeah, there's a couple of studies that have shown that because of using air and oxygen at high flow, you may end up with actually using less oxygen altogether, even though you may be using 30 liters of flow or 35 liters of flow, but it's only supplemented to 40% or 30%. You're actually using less oxygen than you would from a non-rebreather mask, running at 15 liters. So
it's just that during COVID, most of our people were on 100%.
Yeah, that's a problem of demand, not the technique itself. It's obviously on 100%. You're on 100%. It's difficult. So, and then maybe those patients should be intubated, then you use less gas. It's
just to circle back to Ehab's comment on CO2. The Air VO2, there's a release the second release on the item I was sharing before. This is the F&P OptiFlow nasal cannula with CO2 sampling. Yeah. So there you go. That one was basically released in 2017, submitted, so probably released in 2000. Well, let's take a look. Okay, they got this one in decision date in 2021. So
I haven't seen it.
Date right here tells you that K20 they submitted a CO2 sampling now. Okay, so it sounds to me too, what I heard from you guys is that being able to not run necessarily at the default of 37 at the patient interface would be a good thing, being able to control the temperature down. So that makes sense to people who don't want it to be too hot. there's literature in high flow that came out of that Matthew Drake mentioned in his high flow evidence-based assessment. Let me see when this was in 2017 out of Washington, Oregon. Matthew Drake, that he was referencing some studies where below 37 degrees was showing issues with nasopharyngeal epithelium and mucociliary clearance, et cetera, et cetera. I don't know. To me, you're not bypassing the normal humidification system. You may be passing it really fast and not allowing for normal humidity transfer. But I think it would be helpful to be able to turn the temperature down from 37 to 34, maybe, or something below that. Well, guys, I think this was an important discussion, and I thank you for your time. Are there any final thoughts before we wrap this up?
That was great. Thank you for having me. I really learned a lot today. Thank you.
Steve.